right. Thank you everyone for joining us this evening for our Running Medicine National Grand Rounds. I'm Sara Raiser coming to you from University of Virginia Runners Clinic in Charlottesville, Virginia, and we're very excited to host this March edition of Grand Rounds today. Surrounding our annual UVA Running Medicine Conference is going to be held this Friday. You can still sign up if you're interested. It's going to be virtual. So please reference the email that was sent out recently or post in the Q&A. I'm happy to give you information on it if you're interested. We've also got, if you're in Charlottesville, we've got a couple other sessions going on. We've got a PM&R department grand rounds on athletic identity from physical therapist who's a runner herself, and an interdisciplinary conference on Monday too. So those are open to the community. Feel free to join us if you happen to be in town. Our next session, just looking ahead for National Grand Rounds, is going to be in April and is going to be on pelvic floor in the runner. We've got a physical therapist who's going to chat with us, coming locally from Charlottesville as well. We're going to do things just a little bit differently this evening. So I'm getting things kicked off here with Dr. Adam Tenforde. We're going to wrap things up towards the end of the hour with Dr. Angela Rick, who's one of our PM&R residents at UVA, also a former D1 runner herself. So if you have any questions that come up as we're coming through the session today, feel free to throw them into the chat, and we'll address them at the end of our session today. We'll try to stick to an hour to respect everyone's time, so I know these are precious evening hours these days. So without further ado, I'm going to introduce Dr. Adam Tenforde. He's an All-American collegiate and professional distance runner turned PM&R physician. He's the director of running medicine at the Spalding National Running Center and was our keynote speaker last year at our annual running medicine conference at UVA. His research interests include bone health in athletes, prevention of overuse injuries, and foot and ankle conditions. So a great person to be giving us a little segue here with bone health in the runner. So thank you.
Well, thanks for having me, and a quick plug for your annual meeting on Friday. That looks like a star-studded cast, so definitely encourage people to sign up for that. What a great experience participating last year. So I'm going to talk a little bit on bone health in the runner, and just in terms of conflicts of interest, non-relevant to disclose on this topic. So, yeah, as you heard, my background is really, in the sport of long distance running. For me, the challenging injury was Achilles tendinopathy, but certainly saw a number of athletes that were really sidelined with these issues around bone health and how that can lead to other factors such as bone stress injuries. So a lot of that's informed my interest. And again, my family includes my wife, who is a more accomplished runner than me, having made an Olympic team. So, this is a real personal story for us on our desire to keep runners healthy. I'm going to go into this talk, though, talking a little bit more globally on what do we understand about the influence of sport in bone health. And then why do we think runners might be more susceptible to having impaired bone health? What can we learn from some of the injuries that a runner sustains? And then how can we think about an approach for management? So first off, getting into the topic of how we think about bone, it really plays a critical role in our overall functional status. And there are a number of different ways this can affect us in physiatry, understanding that athletes that have low bone mass for age can be at risk for bone stress injuries. And in older athletes, including runners, we can start to get into the concept of osteopenia and osteoporosis. And the concerns, of course, are that when you cyclically load a bone can fail, leading to a bone stress injury. But with age, we really start to worry about skeletal fragility and developing insufficiency fractures. And then we also need to recognize that sometimes our masters athletes could in fact have impaired bone mass and could be a masters runner where there can be a little bit of an intersection. So historically, we've really thought about bone health as being an issue that was limited to older athletes. Then came along in the early 90s this concept of the female athlete triad. But the more that we've understood populations, and a lot of our work has come from runners, is that you can have low bone mass whether you're a man or a woman, and that can change over time, different risk factors for injuries. Younger athletes, though, in particular, are an area of interest because this is a time of reaching peak bone mass acquisition. So we like to think about this in our youth runners and what we can do to maintain their bone health. So I'll get a little bit here in on the sports participation piece, the athletes that are at risk, which we think to be runners, and then how do we approach a workup and management for impaired bone health. So there are two main factors that we need to think about when we describe the influence of skeletal loading on bone. The first, which I think is familiar to most, is this concept of Wolff's Law. The bone really adapts to different mechanical stresses and other changes in environment. For example, when astronauts go into space, when they return to Earth and they experience those increased gravitational forces, they can have pretty significant bone loss, and there are strategies around doing weightlifting and other resistance exercises in space to try to reduce the bone loss from that. But suffice to say, those are individuals that are losing skeletal mass that have already reached their peak age. In the younger population, we talk about this concept of a muscle bone unit theory. And this says that outside of trauma, the stress that soft tissue and tendon places against bone promotes the most changes in bone development. There are two main strategies that we can look at bone strength and bone architecture. The first is what we really use more clinically, which is dual X-ray absorptiometry, or DEXA. And really what DEXA is it's a two-dimensional X-ray which can be extrapolated to a three-dimensional measurement of density. And density of bone is thought to be a proxy of strength, although it's not a perfect way of understanding the strength of a bone to withstand forces. We use DEXA to identify those with impaired bone health, those that meet the criteria of low bone mass for age, or in older adults, there are standardized criteria of osteopenia and osteoporosis. When we do more research, we'll also use high resolution peripheral quantitated computed tomography. And these are CT scans that actually look at us, that allow for us to look at three-dimensional strength of bone and actually do different forms of modeling of stresses to bone using finite element analysis. And this can help us to understand more strength differences. Now, this is really limited to research, and most protocols are performed in either the tibia or the distal radius. So again, we're pretty limited in what we can use this technology for clinically, but I will discuss this in some of the following slides when we start to compare different populations. So again, criteria are important. And commonly people will get a printout of their DEXA, and it may not be read correctly for the patient population, or they may refer to an athlete as having bone mass within normal, but that may be the normal that's been published for the general population and not specific to the athlete. So the first thing to understand is there's the criteria from this group called the International Society of Clinical Densitometry. And they set some of the standards for how we think about bone and how we interpret DEXA scans. And they'll use the term low bone mass for age as a BMD, so bone mineral density, or a BMC, bone mineral content, Z-score of less than negative 2.0. Now, a Z-score is a standard for age, sex, and ethnicity normative values. But these values are for the general population. We have to understand that typically participation in sports leads to a 5 to 15% higher bone mass. So the American College of Sports Medicine will define low bone mass for age in female athletes participating in weight-bearing sports with a bone mineral density or a bone mineral content Z-score of less than negative 1.0. We've also proposed a similar threshold for male athletes. So really this criteria of a Z-score below -1.0 may be a marker for impaired skeletal health and is oftentimes what we'll use to do further evaluation of impaired bone health. And again, athletes should have anywhere from 5 to 15% higher bone mass than non-athletes. So in general, we think weight bearing is good. And so it's surprising sometimes to our patients and general population when you describe an activity like running as being sometimes associated with impaired bone health. So let's get into a little bit more on why that might be. Um, and the other aspect that we want to think about as we approach this discussion is that 90% of peak bone mass is reached by the ages of 18 to 20 in female and in male athletes. So again, there's always the question of what would be the appropriate activity to do in younger ages. In particular, we think that early puberty is a really important time. This is where 26% of final bone mass is reached. And typically that's between 11.5 to 13.5 in girls and 13.5 to 15.5 in boys. If you widen that out by 2 years though, and you really kind of look at, the ages of 10 to 14 in girls and 12 to 16 in boys, that might be a time where up to 40% of peak bone mass is reached. So these are times where we really want to encourage weight-bearing sports. And the question is, what sports do you encourage? So that question we tried to answer well over a decade ago. This was a review that I did with Mike Fredrickson. And this was looking at the evidence at that time of sports participation and its influence on bone health in the young athlete. And again, this is probably one of my better cited articles. I wouldn't say that the data that's come out subsequently has been significantly different from what we concluded. And what we wanted to do, though, is kind of inform some of the subsequent work we were doing, looking at whether certain sports protected against bone stress injury in the future. So we took these four different categories, primarily high impact, multi-directional impact, repetitive low impact, and non-impact activities. And really the question was, if you create these categories based on the types of directions and ground reaction forces, you might be able to start to understand how different activities influence bone health. What we found is that those sports involving high impact and multi-directional loading, such as ball sports or gymnastics or volleyball, tended to have higher bone mass and greater bone geometry, particularly in the anatomical sites loaded. And when you really break it down, that means that you can have an upper extremity, sport athlete like a racket sport, where the dominant arm can have significantly higher bone strength than the non-dominant arm. And some of this has been modeled by Stu Warden at Indiana, where when you describe the velocities that a pitcher needs to achieve in Major League Baseball, if a bone didn't adapt to those loads, that torque would break most people's arms throwing a ball at 100 miles an hour. So it makes sense that the skeleton is going to gradually respond to those increases in demands over the time of exercise. But when we look at the sport of long distance running, what's unfortunate is that most of the studies do not show greater gains in bone mass or geometry, or at least a predictable gain across studies. And a lot of this is probably explained by this concept of Burr's theory of cellular desensitization, that repetitive stresses in the same direction probably don't lead to the right mechanical stress to lead to a more robust skeleton. And another, kind of interesting point with all of this is that we get a lot of athletes that feel like they're doing other activities. And those activities can be good for cardiovascular benefits, such as cycling or swimming. But in some cases, those athletes might actually have weaker bones, at least in terms of bone bone density than non-athletes. And a lot of that is either due to the hypogravitational forces of swimming, or perhaps with cycling, where you might be putting some stress through the tissues. You're not really providing much mechanical loading, but you certainly are putting those athletes in sometimes periods of low energy availability from the prolonged endurance activity. So when we really look at crossover benefits in sports, now this was another part of the review. It was interesting to note that those individuals who had participated in ball sports around the time of puberty, particularly for 2 or more years in the military, would see anywhere from a 42 to 84% reduction in development of a bone stress injury. And in that time, they referred to them as stress fractures. Not all bone stress injuries are stress fractures, but what they're really describing is overuse injuries to bone. This, and again, this was then during basic Israeli military training. So participation during puberty, and then those that were going into basic training as young adults. Well, Mike Fredrickson was able to subsequently, replicate these findings in elite track and field athletes that had qualified for the 2002 and 2003 national championships at Stanford. And he found that those that were participating in soccer or basketball during adolescence had a 50% reduction in bone injury. And he was identifying approximately a 13% reduction in the risk of developing a bone stress injury for each additional year, suggesting a dose-dependent relationship. But within that population, the female athletes with menstrual irregularities did not have protective effects, suggesting that the load is important, but the other sex hormones are also important for leading the bones to being responsive to load and to gaining bone mass. We were also able to see this in a youth athlete population, where we were looking at modifiable risk factors for bone injuries in high school athletes. And we found that prior participation in basketball was associated with an 82% reduction in development of a bone stress injury, suggesting again a closer temporal relationship and a greater, possible causal mechanism. So why do we think these ball sports might confer benefits? If we break down running, it's about 1,000 single leg squats, hops, and landings without falling down per mile. I mean, that's really the biomechanics of running. These are typically a peak, body weights anywhere from 2 to 2.5, or, some will say 2.5 to 3 times body weight. And most of this is done in a sagittal plane. When you contrast that to the sport of soccer, or as the rest of the world calls it, football, it's probably fewer loading cycles, but done at much higher peak impacts with a lot more cutting and multi-directional loading. That's going to put increased demands through the skeleton, probably leading to stronger and stiffer bones. And this has played out in some of the work that Mike Fredrickson did, comparing collegiate runners to soccer players to sedentary individuals. These were all male athletes. And really what you see with soccer is that bone strength is superior across running and control populations. The only area where bone mass was greater in runners compared to controls was the calcaneus, which was postulated to be due to the fact that most runners are rear foot strike. So really what we conclude from looking at these early studies is that it appears that endurance sports such as running and non-impact sports may be the athlete populations at a higher risk for having impaired bone health. So then we really kind of want to dive into a little bit more on why this might be. And a few of these things come down to earlier concepts around the female athlete triad, the parallel concept of a male athlete triad. And basically this triad is discussing the interrelationship of energy availability, hormonal function, and how both the hormonal and the nutritional milieu will influence bone health, but also thinking of these on a spectrum. So athletes can have low energy availability, which can affect menstrual periods, or can cause male athletes to have lower than normal physiological testosterone, and that can lead to a reduction in bone mass. Relative energy deficiency in sport is the term that's used, I would say, more commonly now in the sports medicine community, particularly outside of the United States. And that's really describing this concept of low energy availability having effects not only on menstrual function and bone health, but across a number of different physiological systems. I apologize, this is not the most updated schematic, and if you really want to be in the know, you now refer to relative energy deficiency in sport as REDS, R-E-D with a lowercase s. But again, both of these groups are discussing why low energy availability has multiple effects on health and why it's important to identify and address. So what we think happens with low energy availability is that it has a downregulation on the brain and hypothalamus. This leads to a reduction in sex hormones, leading to menstrual dysfunction and a reduction in bone mass, or in males, that hypogonadal state. You can have a reduction in growth hormone sensitivity, which then leads to further muscle and bone loss. It leads to a reduction in thyroid hormones, and this is actually suppressing metabolism. And a lot of these athletes will say they feel less hungry, their metabolism is down, therefore they're eating less. And again, the goal is to actually encourage those athletes to increase their energy availability, which should restore a more normal metabolism. And then finally, you can have an elevation in stress hormones such as cortisol, which can further put the athlete into a catabolic state. And athletes really want to be in a state in which they're recovering and building. So again, this is why we want to avoid this low energy availability state. In contrast with adequate energy availability, you should have normal sex hormones, you should have normal growth hormones, thyroid hormone function should be normalized, and normal response to stress hormones would be expected. So why the sport of running, and why this low bone mass? Well, we can go into a number of these different populations to kind of explore what we've learned about running, and some of the background on the physical activity, and these concepts of low energy availability are important to build on. So let's talk about these populations. But first, we've looked at adolescent runners, and this was some of the early work I did during medical school and residency. 748 high school runners who were in the San Francisco Bay Area, participating at 28 high schools. We were looking at their risk for developing a bone stress injury, but we also were able to obtain DEXAs in a large number of these runners. And what we identified is that, a large portion of girls and boys had bone mineral density values with Z-scores at that negative 1.0 threshold. And we found that in these female runners, that having a BMI of 17.5 or less, or the combination of prior fracture with menstrual dysfunction, was a risk factor for having low bone mass. In males, this concept of 17.5 was also important, which actually reflects what a number of kind of professional societies have suggested as being an actual BMI cutoff where you're concerned about the low energy availability state, but also this concept that being thinner leads to faster running for performances. If boys agreed with that, that was associated with lower bone mass, perhaps reflecting a screening question for athletes that might be at increased risk for low energy availability. We've looked at other populations such as young male athletes, and this was some work that I did with Kate Ackerman, where there were, I believe, 29 runners who, well, I apologize. This is not that study. This was actually a pooling of data with Michelle Barrick. And what we looked at was actually 69 male athletes. Most of them were runners from that initial cohort, but we were also looking at soccer and basketball players and trying to see who had low bone mass. And there were 4 factors that really jumped out in this population. The first was running volume exceeding 30 miles per week. The second was history of a bone stress injury. The third was having less than 85% of expected body weight. And then the fourth was consuming less than 1 serving of calcium per day. And really, as you get more of these factors, there was a cumulative risk for having low bone mass. And again, in a population of 13 to 19-year-old male runners, these may be important factors to consider. We've also looked at collegiate athletes, and this was 323 Division I athletes at Stanford participating in 17 sports. We were looking at individuals from 2008 to 2014 that had pre-participation examinations and had participated in DEXA not because of injury, but more to participate in what was meant to be a normative database. And we were looking at risks associated with developing a bone stress injury, but also understanding bone health across this population. And really what we identified in looking at this population is that highest bone mineral density values we're seeing again in these sports described in adolescence, but this is now in young adult women in college, participating in basketball, gymnastics, volleyball, basketball, and softball. Again, primarily sports that we had referred to as high impact or multi-directional. And the populations with the lowest bone mineral density were, not surprisingly, athletes that were on the cross country team, those that participated in crew, swimming, and synchronized swimming. Again, sports that are endurance based or have an emphasis on aesthetics and leanness. And what seemed to be, the greatest, combined risk factors for low bone mass in this population was a lower BMI, oligomenorrhea, amenorrhea, and then those sports, including synchronized swimming, swimming and diving, and cross country. So again, you can use this triad coalition scoring system to identify athletes at low, moderate, or high risk. And again, these are 6 items that I think are pretty helpful for screening athletes. Again, low energy availability, different cutoffs for BMI, individuals with delayed menarche, secondary oligomenorrhea or amenorrhea, which now is being referred to as abnormal uterine bleeding. But again, the terminology, just figuring out how to decipher this and communicate to the athletes important. Low bone mass, low bone mineral density if you have DEXA, and then the number of bone stress injuries. And you can use this to determine low, moderate, or high risk. And that can further inform your clinical decision making and guidance on whether this athlete needs to be under kind of increased work with a multidisciplinary team to ensure that their energy availability is appropriate, or in the more extreme cases where they have untreated eating disorder or other health concerns that would make it unsafe for them to participate, considering disqualification, although this is very rarely recommended. So again, using this triad risk category, we were also looking at the populations that seem to have bone stress injury, and we were finding that athletes in the moderate and high risk category were at a greater risk for developing a bone injury than low risk. But if you really look in that middle column, you see the cross country runners were 12.5% who were low risk, half that were moderate risk, and 71% that were high risk sustained a bone stress injury within a year. So really, kind of the equivalent of a flip of a coin that within 12 months of being at an elevated risk category, these female athletes were developing bone injuries, suggesting the value of really encouraging these athletes to engage with meeting with the sports dietitian. But another interesting factor was looking at where these bone stress injuries occurred and whether they may be a surrogate for identifying athletes that have a greater burden of triad risk factors or might have lower bone mass. And it was interesting to note that if you break down bone as having, more of trabecular rich content, such as the femoral neck or the sacrum, those tended to be in the athletes that met the criteria for moderate or high risk. Whereas in the low risk athletes, such as basketball, those were the individuals that were getting bone stress injuries in the feet in these more cortically rich bones, such as the metatarsal or the tarsal navicular. So this work has been identified in other studies an early study by Marks out of HSS in 2001 identified that athletes that had these bone stress injuries in the pelvis had a threefold increased risk of low bone mass compared to those that had bone stress injuries in other locations, such as the tibia. The study that I kind of jumped the gun on discussing was looking at male athletes presenting with one or more bone stress injury. This was a collaboration with Kate Ackerman and 29 male athletes between ages 14 and 35 that had one or more bone stress injury and had DEXA. And it was really found that those male athletes with a low bone mineral density were more commonly seen in runners. There was about a six-fold increased risk for having low bone mass, and those that had a trabecular-rich bone stress injury. Again, suggesting that, you know, you have a male runner with like a sacral bone stress injury, you should be concerned about impaired bone mass and thinking about a DEXA. Why we think this may happen is related to how sex hormones may affect different compartments of the bone. So there are two main components of bone, with the cortical outer shell, which really gives bone a lot of its strength. It's very dense, it's very compact, and the turnover is much slower when compared to the trabecular bone. And the trabecular bone is the more spongy bone that has more of a honeycomb appearance, greater surface area, and is thought to be more sensitive to disruptions in sex hormones. So this has been, you know, postulated to be the explanation for why athletes develop more proximal bone stress injuries if they have low energy availability and disruptions to hormones, and why they may have lower bone mass. Has been substantiated by work by Kate Ackerman demonstrating, you know, increased spacing and decreased number of trabeculae in female athletes with history of amenorrhea. And so what we believe currently is that bones such as the lumbar spine and pelvis, and actually the calcaneus appear to have much more trabecular bone content than cortical bone, and these may be markers for low bone mass and uh, due to disruptions to hormones that might preferentially affect those bones or cause those bones to be the site of injury. So when we're thinking about strategies to optimize bone health, we really want to think about, you know, whether you use female or male athlete triad risk stratification or REDS, identifying those athletes at risk for low bone mass, ensuring they're getting adequate calcium and vitamin D, promoting adequate sleep, and loading activities. And we'll get into each of these. So risk stratification, whether you use REDS CAT version 2 or female or male athlete triad coalition statement, identify a strategy that works. I find this triad coalition statement's a little easier to follow. Identify athletes at increased risk, and if you find people that are in that moderate risk or high risk category, they should really get a DEXA. If we look at the concept of calcium and vitamin D on bone health, we had done a review on this a number of years back, and it really appears that calcium and vitamin D intake may help to prevent bone stress injury. The question on whether it prevents fragility fractures, more recent literature has been a little less supportive of that. But oftentimes we find our athletes are not getting enough calcium and vitamin D in their diet to optimize their bone health. So some of the work that's been done, this was a study by Joan Lappy in Navy female military recruits. Intention to treat with 2,000 milligrams of calcium and 800 international units of vitamin D resulted in a 20% reduction in development of bone stress injuries in this population. Now there's separate work, and this study was great. It was led by Kristen Ciani, who's been a good friend and collaborator of mine over the years. But this was a sub-analysis performed by Jerry Knives of the original data that they were obtaining on seeing whether oral contraceptive pills prevent bone stress injuries in female athletes. What they concluded in that study was they don't, but what they were also able to do was get baseline nutrition and look at what factors at baseline were predictive of development of a bone stress injury over that 2 years of observation and interventional study. And they found that particularly calcium from drinking milk might be important because every cup of milk consumed reduced the risk of a bone stress injury in the study by 62%. So again, I like to highlight that and talk about that in athletes that I'm seeing with bone stress injury and talking about ways to optimize bone health, of just making sure that athletes aren't focusing on supplements and they're taking in foods that are rich in protein, phosphorus, calcium, milk, fat, protein. There's a number of different building blocks that contribute to bone health and to getting an adequate energy availability. So encouraging calcium-rich foods is a good idea. And I've occasionally been challenged on that assumption in other literature suggesting milk is associated with increased risk for adverse bone outcomes. But I think it's perhaps not a fair comparison when you're really looking at the running athlete population we're looking at. I still think calcium from the diet is most important. And what was also interesting from the study by Jerry Knives is that those individuals consuming less than 800 milligrams of calcium had a six-fold increased risk of sustaining a bone stress injury compared to those consuming more than 1,500 milligrams of calcium. So you'll also see in some recommendations that calcium intake, you may want to target a higher level. I don't know if I would personally recommend 1,500 milligrams because of the concern around, promoting atherosclerosis by excessive calcium intake or the risk for kidney stones. But there have been some studies suggesting we should aim for a higher calcium intake level, particularly in female athletes with low bone mass and amenorrhea. What's important to recognize is where are we with our current understanding and calcium intake, again, in the time of adolescence, 9 to 18, is 1,300 milligrams for both men and women. There are differences as we age for lactating women or women at the time of menopause, 51 and older. They should consume 1,200 milligrams of calcium. Males at 71 and older should be also consuming 1,200 milligrams of calcium. And when you look at the upper limits of calcium intake, again, concerns around probably kidney stones at the younger age, but in the older ages, promoting heart disease. There still is a pretty good safety profile, but the key bioavailability of calcium is about 500 milligrams. So making sure 1 or 2 servings of calcium-rich foods in each of 3 meals should typically hit the mark. Vitamin D, those guidelines continue to be adjusted. It used to be 200 international units. We're now up to recognizing probably 600 international units for most age populations, and perhaps even higher for older adults after 70. The next consideration outside of optimizing energy availability and calcium and vitamin D is thinking about sleep. This is a study that I think is really interesting, again, in the military, where they took these 18-year-olds and they were forced to either sleep sitting in a chair, were sleep deprived for 62 hours, or were allowed to sleep in a typical horizontal position. And they were measuring changes in bone density and calcium turnover. And what they found is the sleep deprivation state for 40% of individuals, there was significant turnover of bone, along with a 5% reduction in bone mass. So that would be the equivalent of going down a full standard deviation in bone health. So when we think about runners and other, populations, we're a little type A, we're probably not sleeping as much and we're pushing the envelope when we're trying to get in more hours for training. We really need to emphasize sleep, and particularly if someone's recovering from a bone injury, ensuring they're not trading off getting adequate sleep to do more cross training. It's also interesting to note in the military, when they reduced military training volume and instituted minimum sleep requirement, they were able to reduce the risk of the overall rate of bone stress injuries by 62% compared to a historical cohort. The injuries were lower grade, and they were also finding that the subset that stayed healthy was actually seeing increases in bone strength, suggesting you can modify some of the risks around bone stress injury. DEXA, again, as a reminder, if you use the triad coalition statement, it's really 1 high risk or 2 moderate risk factors should lead you to get a DEXA. But remember, whenever someone's recovering from a bone injury or whenever they're instituting a major change in their bone health, it can take up to 6 months for bone to get back to or to respond to the load or to get back to full strength. And this was some interesting work that I did with Christy Pop, Kate Ackerman, Mary Buckstein, where we were taking athletes that had a tibial bone injury, and within 2 weeks they were getting a CT at visit one. Visit two was 6 weeks. Visit three was 3 months. Visit four was 6 months, and visit five was a year. And what we see is that bone strength, both in the injured and uninjured limb, was at its lowest at 3 months, and it took a full 6 months to recover. So really thinking about the fact that bone does may have a life cycle of about 6 months. And this can also explain why athletes with impaired bone health need to increase things gradually to ensure that their bones have adequate time to respond to those loads and to repair. From a pharmacotherapy standpoint, just a few words on this. We really focus on nutrition, but there are a number of options that we'll think about in older populations. That would be primarily the anti-resorptives or the bisphosphonates. We don't use these in younger athletes, particularly women, because they are a known teratogen. I believe it's renal agenesis that we're concerned about if a fetus is exposed to bisphosphonate, and they have a long half-life. So that's why we really rarely will use these in women, particularly during childbearing years. There are a number of other medications, but they're a little less well studied for increasing bone mass. Forteo or other parathyroid hormone-related peptides are anabolic agents that are sometimes considered for high-level athletes. And in rare cases, I've seen them used in athletes, but typically they require some type of a bisphosphonate to maintain bone mass. And the medications themselves are extremely expensive, require daily injections, and as a result are very rarely used in clinical practice. So really an important consideration is that for the female athlete that has low bone mass or is having recurrent bone stress injuries with oligamenorrhea or amenorrhea, there may be a role for doing the equivalent of hormone replacement therapy using transdermal estrogen with oral progesterone, or another strategy could be the use of a low-dose progesterone IUD to kind of minimize the exposure of progesterone, but to reduce the risk of concerns around unopposed estradiol on endometrial hyperplasia, as being a strategy to try to kind of normalize sex hormones in the female athlete for bone turnover and hopefully small amounts of bone gain. But remember to keep your plans individualized. The recommendations that we might use in a youth athlete that's still growing are going to be very different than the recommendations for the postpartum athlete. And I was able to work with Dr. Reiser on this review on bone health in the master's athlete. And again, the concept is we need to think about these populations differently, and the recommendations should be really tailored to the athlete and where they are in their stage of life, because it's important for individuals to have healthy bones that allow for them to enjoy sport and also to reduce the risk of morbidity with fracture later on in life. So really think about optimizing skeletal health with identifying those athletes with low energy availability, promoting bone loading at an early age, ensuring adequate sleep, and really focusing on the nutrition. And in particular, my recommendation is think about these ball sports, soccer, basketball, and in particular during the time of puberty, really, this is the thing I think about for my kids, making sure they're doing something like basketball and soccer, because this may really have a legacy effect that keeps bones stronger if they get involved in endurance running, and even if they don't, just to have healthy bones their whole lives. So in summary, bone health is influenced by a number of different factors, including mechanical load. Endurance runners and other, endurance sports seem to be a particular risk for impaired bone health and risk for bone stress injury. So we should think about doing a better job with optimizing and screening for skeletal health concerns. identifying the low energy availability state, promoting early bone loading, sleep, and nutrition. So with that, this is kind of the cute photo of my daughter. This is like her first time playing soccer, and she just, she's out there. She was like sleeping like a champ, and she had like her like sippy cup of milk, and it's supposed to be fun, especially at younger ages. So, at any rate, really appreciate your attention, and I'll turn it over to the rest of the program, but also happy to answer any questions.
Great. Thanks so much, Dr. Tenforde. We do have a question in the chat. From a nutrition standpoint, is there anything else you like to recommend to your patients beyond calcium and vitamin D?
Yeah, so I tend to be someone who is not a huge proponent of supplements. I think where it's challenging is if you have an athlete that's lactose intolerant or has some kind of malabsorption issue, you may need to take a supplement. And on an empty stomach, you really need to be thinking about calcium citrate as opposed to calcium carbonate, which tends to be activated through, eating something like Tums, but with a meal, to actually allow the bioavailability to be improved. Vitamin D, sun exposure and diet, it's very difficult to hit the vitamin D target. So I think supplements with vitamin D and iron are the two main areas. And that's its own talk, but general pearls and pitfalls. Iron first thing in the morning, empty stomach, a little bit of OJ. Stomach pain is a sign you're probably absorbing it, and waiting at least a half hour before having a meal. And hopefully that meal is not having tea, caffeine, or other phytochemicals that may bind the iron, or calcium rich food that might compete for the iron absorption. So those are really the two big ones: vitamin D, iron.
Great. Thank you. You talked a lot about how adolescents, during that period of their lives is when they're laying down so much of their peak bone mass, as large percentages that you shared. So when seeing that population in clinic with bone stress injuries, are you treating those athletes differently in terms of how you approach that bone stress injury? Are you keeping them out for longer or doing anything different with that in mind?
Yeah, I mean, it's a good question. Like, does the age of the athlete really change like their recovery or their healing? I think what we should keep in mind is you can have a younger athlete that's struggling with a bone injury, and adolescents are not like small adults. They are growing. The part that's really remarkable is at the very young ages, their bones will heal much quicker than people that are old and busted. And so that's the first thing, is like being comfortable and experienced, and to recognize different injuries. So like, for example, an injury next to a growth plate may require further consideration than the bone stress injury that they may have in the posterior medial distal tibia. I would say that these are times though to have the anticipatory guidance both with the athlete and with the parent and guardian, because at the end of the day, I think most parents want what's best for their kids, and education plays a huge role. So discouraging early sports specialization in runners. I mean, my daughter, she's 12. She likes going for runs with me, and it's fun. But she's doing a lot of other sports, and just language around food, language around sport being fun. It's Brian Krayback will talk about it. It's like kid directed and parent protected. You really want the athlete out there, and you really want them avoiding early sports specialization, particularly in the sport of running. So that kind of answers the question. There's not a perfect way to change things, but those are a couple of like key considerations to put into play. And then the final one is that the risk for bone injury may change over time. And at least in the military, there seems to be about a 29% reduction for every increased year of age in basic military training. So it's the concept sometimes that you'll have the athlete that really struggles during that time where they're growing because their bones get longer before they fully fill in and become as dense and strong as they should be. So reminding the athlete and making sure you're giving them an opportunity. But the final piece is on the transdermal estrogen story. Sometimes you will have the female athlete that had late menarche, their energy availability wasn't optimal, and you're really trying to figure out, like, if you have a couple of years to really improve bone health, if their bone mass is low, you may actually think about the transdermal estrogen. It seems a little aggressive, but there are these windows of opportunity where, thinking about, whether the pros and cons may make a lot of sense. But that's one of the things that I was disappointed in some of the early stages of my career, where I'd screen an athlete, find out that she had primary amenorrhea, and I would send them to someone who didn't understand how to manage that, and they'd be put on oral contraceptive pills, and that didn't help anyone. They didn't need them for a medical reason or for contraception. They were just being told to go on them, as opposed to getting them in to see a dietitian and having a discussion on what the menstrual period represents. It's a vital sign in the female athlete, and it can be very helpful for monitoring overall energy intake.
Excellent. So we have another question. What recommendations do you have for novice runners to avoid bone stress injuries?
It's a great question. I think what we think about is remembering that bone loading. You actually have these macro cycles of bone recovery, but you also have these microcycles. So I really like the work by Rich Willey, which has discussed, loading the bone and maybe every 3 weeks dropping by a third of the volume, or every 4 weeks dropping by maybe like 40%. So what that might look like is an athlete runs, 15 miles of volume, then 18 miles, but then deliberately drops by a third, might go to 12. That might go back up to 18, 22, drop down to 15. It's different than the way that I thought about bone loading and recovery, where it was like you took a high week and a low week and you alternated. It really does seem these cycles need to be every 3 to 4 weeks. And that might not be the most palatable thing for a college coach to be told, like, drop the volume by a third. But there does need to be some variability, because bone gets stressed and it needs that offloading to recover. I think the other piece too is recognizing that there's no magical volume, and a lot of these cause-based runners that might be like, I'm doing a marathon for a charity team, they see these numbers like, I need to do a 22-mile long run to run a marathon. That's completely a fabricated number. In Europe, they use kilometers, so a 30-kilometer long run is considered like a mark for being ready for a 42.2-kilometer event. And yet in the US, we're obsessed with the metrics, or the English system. So, just helping athletes to understand the most important tenets of listening to your body. I think that's the best thing that you could tell any runners getting into things. And understanding pain that, gradually improves is fine, but a pain that builds when you exercise, or joints that swell, those are times where they really need to see one of us so that we can give them some good guidance.
You mentioned, talking with college coaches, and sometimes these conversations can be difficult. And so that gets me thinking, that risk stratification tool that you shared, I'm kind of wondering who out there is using that, and how do they go about kind of having these conversations with college coaches where, an athlete may present as very high risk, but at the time when the coach is standing there looking at them, they're running fast, they look ready to compete. How do you kind of navigate that process?
Yeah, well, you want to center it on what are the goals for the coach and the athlete. And if the in my experience, if you go into it saying like you're going to get injured, you're not going to make any progress. If you come in and you say, hey, look, I'm interested in keeping you healthy and recovering and feeling well, That's a much more appealing discussion. Like, how do we get you recovering? How do we keep you consistent with your training? Like, no one's going to disagree with that. We went through a 7-year, study with Stanford and UCLA, and we decided to title it the Healthy Runner Project because we really didn't want to focus on like stress fracture injury project. Like that that doesn't sound like a really exciting thing, and there are concerns that talking about injuries sometimes leads athletes to get in their own head, and then there can be these patterns where like one athlete gets injured, a bunch of people get injured. It's not that a bone stress injury is contagious, but the culture and the fear around it and the behaviors around eating, there's a lot about a culture shift. And that's really, I think, where talking to a coach, helping them to understand like what is known, like meeting with a dietitian, to be proactive about feeling in recovery. The conversation should be very individualized, like when not to stereotype, but like on the like Stanford team, when like the guys met with the dietitian, they're like, oh wow, I can eat a lot more, that's cool. But you have to approach it maybe a little bit differently with female athletes, where there might be more of a culture or a fear around gaining weight, and then it's really a discussion about like what are the targets for eating, and then how do you think about it as like recovery and about being strong and running, as opposed to like focusing on like being really thin. So it's not an easy topic, and even that study, we didn't have the results we were looking for, which was to see like a consistent reduction in bone injuries. We saw a difference in one site but not the other, and some of the concerns between those two sites was turnover of coaches, the culture, the buy-in from the athletes and the coaching staff about participating in the study. All those things can sometimes interfere with the athlete getting the information they need. And so it's really just about building trust, as it is with like most things in medicine, and as people get that trust, then you have a better opportunity to help them. But unfortunately, most of the time when we're really getting to be this proactive, it's when the athlete comes in with an injury, and at that point they're all ears. They want to get healthy, and then it's easy to forget the further you get away, because a lot of these things are not the easiest things to maintain. So I try to just remind them, I'm like, look, we're all human, we're going to make mistakes. Goal is to be able to enjoy the sport. It's supposed to be fun. It's supposed to be fun. Yeah. And don't forget about sports psychology. I think that's huge. I think a lot of these athletes, when they have a bone injury, it's very overwhelming. And we should be creating environments where they feel safe and they can have discussions. And that leads into the a lot of the concerns around mental health, and a very alarming study that actually came out showing that male cross country runners apparently had the highest rate of suicide across all collegiate sports. And again, I was like, it's a relatively uncommon event, but if you think about these sports and high rates of injury in certain populations and the psychological toll that takes on athletes, I think it's something we're missing. And it certainly will feed into, mental health will feed into eating, but it also just feeds into, what athletes are supposed to get out of the sport, which is you're supposed to grow through it. You're not supposed to like suffer through it.
Absolutely. And it looks like we have just 1 minute left, so I'll throw in one final quick question and then we can end on time. So with the data showing that ball sport participation in youth, adolescents, and high school and college reduces fracture risk later in life, is there a benefit for someone who never played ball sports early in life in picking them up later as a means to improve bone health?
I can speak from, getting older. It's good to cross train. It's good to do different activities. I think if in an ideal world, you should do sports you enjoy, and that's why like ball sports for younger kids is good, because it's like you're just chasing after the ball. You're not talking in these abstract that we need to get your bones stronger so that when you're older, you're going to be able to do things, you know? So I think as we age, probably the things we need to be focusing on are maintaining power and doing perhaps some more like jumping plyometrics. So again, remembering that we don't have a perfect way to prevent bone injuries, but if you think about incorporating things like plyometrics in injury prevention, you know, simple things like jump rope or maybe some box hops, but doing them slowly. And remembering you can't just introduce that while you're increasing load, because that cumulative demand goes through the skeletal system. So better to incorporate kind of early on, and then to remember periodization. So you're not just like asking more and more from your bone every week.
Excellent. Thank you. All right. Well, thanks everyone for coming, and thank you, Dr. Tenforde, for speaking and for answering all these wonderful questions. And we look forward to seeing everyone next time at our next National Running Medicine Grand Rounds.
Well, thanks for having me. And yeah, it's a challenging topic, but it's great to see the collective interest. And I'm always happy to be a resource. If anyone ever has follow-up questions, they can reach out.
Thanks so much.